So finally, we're going to come on now to welcome Dr. Pramit Patel, who is the Clinical Director for the Care Collaborative PCN in East Surrey and sits on the board of the NHS Confed's Primary Care Network, but he's also Primary Care Network Leader for the Surrey Heartlands Integrated Care System. So welcome, Pramit.
Hi, thank you, Neil, and thank you, Rich, and thank you to everyone participating today. So I suppose the story that Bekele gave right at the outset was powerful and strong, and I think everything that we design and we shape in our networks has to be centered around real patient experiences. I think, Neil, just going back to what you said, we know COVID has shone a sharp focus on CVD linked issues, and the link to health inequalities is quite stark. And we've seen this more evident in our Black, Asian, minor ethnic minority populations, our learning disability populations, our severe mental illness populations. And we've also seen the risk of cardiovascular disease-related deaths in the most deprived areas, in the most deprived 10%, being twice or being double the number than in the least 10% deprived areas. So we know there are huge correlations there, but also pre-pandemic, we've seen that people are living longer, as Josie's already alluded to. They're living longer. They've got more complex comorbidities as well, such as heart failure and lung disease. Natalie, you've alluded to a couple of them already in terms of sarcoidosis. And they are becoming more and more complex. And they're not just affecting the quality and lives of those individuals, but they're also affecting the quality and lives of relatives, family, carers that support them too. So I think all of these factors actually put pressure on the health and care systems, not just primary care networks, but across the whole system. So, I suppose, guys, what have we been so good at doing? And I think in the NHS, and I think we have been complicit in two ways. One, we've medicalised poverty. And I think, that's something that, PCNs working with system leaders and agencies across the system should be working towards getting rid of. And two, it's, we've been good at providing access, which is not accessible to all. We also know that 40% of people who come to general practice come because they're struggling with life, not because they've got medical illnesses, because they're struggling with life. And therefore, it begs the question, are we clinicians, even though we do our best, with the right intent to try and sort these problems out, are we the best people to help address their needs? I don't think potentially we are. And I think therein lies the issue with over-medicalisation. I'm good at maybe signposting a person with mental health illness to an IAPT organisation for some counselling therapy, or even giving a prescription for some antidepressants. But in actual fact, is that what the person really needs? So I suppose it comes back to the question of what are PCNs and what are primary care networks? And in essence, we are multi-agency, multidisciplinary delivery units working across sectors, serving populations of 30 to 50,000 community residents. And it's that footprint that, we can start to deliver the integrated health and care, working closely with our voluntary care organisations as well. And I suppose the key focus for PCNs is actually the proactive care stuff, using population health management data sets. And it's how we can identify those cohorts using such data sets, working with cross-sector multidisciplinary teams to then target those cohorts appropriately. And I suppose I just wanted to share a live example of what we've been doing in Surrey with one of our PCNs, and it's using the NHS England and Improvement population health management pilot sites. So we've got a PCN who had brought together colleagues from District and Borough Council, practices, adult social care, voluntary care, the acute and community care sector. And they all came together to work around a common purpose. And that common purpose was they wanted to improve the health and well-being for not just the elderly frail, but the 50 to 70-year-old mild to moderate frail who potentially will slip into that severe frail category later on down their lives. And what they did was they came up with a cohort using the population health data. They came up with a cohort which actually had one common theme. You know, they were 50 to 70-year-old cabbie drivers of Pakistani origin who are at high risk of developing cardiovascular disease, diabetes, etc. And these folk don't normally come to healthcare settings. So how are we going to improve their health and well-being? How are we going to reduce the multimorbidity downstream? And I suppose it's having that data, having that knowledge. Okay, here's a cohort that we can go to, but not necessarily pull in. So how do we work with our faith leaders in our mosque? How do we work with the imams? How do we work with community leaders to address some of these issues? You know, how can we reduce ghee intake in their diet? That shouldn't be a medical problem. That's a lifestyle problem. But we're so good at over medicalizing it. That's where I think PCNs can, start thinking about how do we work with colleagues around the system within our 30 to 50,000 populations to start addressing the wider determinants of health. And I suppose, my last comment would be, what is a PCN? Now, PCN isn't just a collaboration of general practices. It really isn't. It's a multi-agency, multidisciplinary delivery unit, and that brings together all the people that I've just spoken about. And I suppose our ambition should be to improve the health and well-being for our local communities, for our local communities, by our local communities. And finally, I can't not say this, but our vaccination program that we've delivered has been a huge success based on some of those fundamental principles, working with colleagues across the sector. And I'm really proud to say that the vaccine bus, which went viral nationally, was actually kickstarted by my organisation, and it's a credit. We were able to go out to people, we were able to go to mosques, go to temples, go to the GRT sites as well, Josie, and actually make a difference, actually try and close that inequalities gap. So it's that proactive work that I think we can do across the system, working with everyone, including volunteers, health and social care and local government, to actually make a difference. So it shouldn't fall upon just one organisation.